steroidotomy for diffuse spasticity, or it is an intrathecal baclofen again for a diffuse spasticity. We will debate afterwards that when selective steroidotomy and when intrathecal baclofen pump with the orthopedicians and the neurosurgeons debating here tomorrow and also in the main conference that which one will be the better one out of the two, or at what age which procedure will be better. So the consensus are going to arrive with our own discussion that when indication for orthopedic surgery and when the indication for neurosurgical procedure, or how both are going to be complementary to each other. With that, back to Dr. Taral and Dr.
So what are the, in short, examination?
So the findings are symmetrical. So he's got a midfoot breach in the foot. He's got the silver skewer test is positive. He's got slight equinus, the knee extended with the heel up, and when I flex the knee, he's getting excessive dorsiflexion. So he has got a tight gastrocnemius and an overly long soleus. No knee flexion contracture. Patella aorta. Increased popliteal angle, unilateral popliteal angle is 90 degrees and bilateral popliteal angle is only about 45 or 50 degrees. So there's a significant hamstring shift. And he also has bilateral inflection contraction, which is about 30 degrees.
Abduction as well?
Abduction spread is good.
Hip abduction is okay. I will check this torsional profile, but because, yeah.
So Dr. Jain also tells us that his quadricep power within the range is very good, which is a very, very important finding.
So I explained to you what it is. So if you and I would like Dr. Abhay to comment on the quadriceps lag. But within the available range, hard as you can. So it's pretty good. Okay? And his passive range is okay. I mean, he's got tightness of his hamstring. But once I have him supine, I can get him completely straight. Okay? So no knee flexion contracture, right? But a significant quadriceps lag. But at maximum extension, he's got good power in his quadriceps. And he's also got good motor control. He's able to isolate the quadriceps and
So those are all good, very important physical finding features which have a big role to play in deciding what our management strategy is going to be.
You give those features smiles. So I generally put, for every good thing I find on clinical evaluation, I will put a smile on, which tells me after my surgery or intervention, how good my result is going to be. So he has good power, he has good selective motor control, hardly any deformity at the joint level. And his control is very good because he can kneel, can you show us these things? Very, very good. Okay? So these are all smileys which tell us that we can expect a favorable result after
good. Perfect. So that is again a very good prognostic feature.
Awesome. Hip extensive stress.
Yeah. So it basically gives an idea as to how much hip extensor power is there. Functionally, it's like a quadriceps lag. So I call this hip extensor lag. Like you have knee extensor lag, this is hip extensor lag. Because some kids will go like this. They can't do this. Okay? So being able to do this means that you can get your hip extended against gravity with your body weight. And this is particularly important when you have children with severe knee flexion contraction. So how do you assess hip extension when you have, or ability to stand when you have someone with a severe knee flexion contraction? The way you do it is to make them kneel down upright. If they can kneel upright, then that is a good prognostic strategy.
So one of the issues I had with the questions raised was the desire for improvement in gait. And an open question to the audience would be, at what age do you think our gait pattern loses the ability to improve with or without intervention? Is there a magic number? Anyone has a guess? Or is it something that you can't answer? Sorry, Judge? After the end of growth. So that is one very important milestone in our lives. Is when you get to the end of childhood, you are of a particular size and particular weight, and and your strength and selective motor control and all those other things are constant features in the cerebral palsy. But what happens with children and who grow up to be adults with cerebral palsy is we find that the reason that GMFC's descriptors changed is because they realized that even with the best interventions in the world, the overall functional ability was different, and the need to use assistive devices increased, the need to try and work out how to change your environment to be more effective also became more relevant. So when parents ask me, will my child's gait improve, an answer that I give that is non-judgmental is I say that I have tools to make them walk differently. So their walking will be different. Now, if their brains work out that that is a more efficient way to walk, then their walking will improve. But if their brains don't work it out, then it doesn't. So you can change the gait, but it may not be an improvement. And like you said very correctly, that is much easier to do when you're younger, because you have the ability to adapt to a growing skeleton. Once you get to adulthood, it is not that easy to do. It's not impossible, but it is not that easy to do.
But as a corollary to this, if a 9-year-old child, his parents come to you and they ask you, should we get a child operated at 10 years age, at 14 years age, or at 18 years age just before marriage? So what would be your answer? Which is the best age? 9. At 9. Yeah. So the better.
Well, yes, but not younger than 6,
Not younger than 6.
unless there are some really serious problems that need dealing. And after 12, only if, see, for us, our patient population is different because they come to us from an early age. So we have the conversation starting much earlier, even though we may not decide to do things till later. Whereas I recognize that it's very different here, and you have to kind of accept that.
So, can I make some point on this? I think we are talking about the orthopedic surgery at the 9 years age. So one thing what has been raised is when the pattern we can change. That is what we wanted to know, isn't it?
Yes.
So I don't think that we are changing the pattern after 20 years or cannot be. The time when the brain is maturing, at that time, that is the maximum we feel about the 5 years, any kind of intervention can make some change in the change of the pattern before the brain fully develops. So, as a neurosurgeon, we would like as soon as possible physical therapy, no doubt about it. And once a resistance to physical therapy develops, and if, as Dr. Abhay said, that in Asian population they come late, etc., so many of those things are out for our medical point of discussion. If we have started the therapy early age, I feel by the age of 3 years, when the full picture of the cerebral palsy develops, even some are hypotonic, becomes spastic by the age of 3 years. So, any intervention at that time might help to change the pattern. But once the brain has matured, the changing the pattern is perhaps extremely difficult. And if it is a severe pattern, I don't think that one can tell, because the brain has learned the way it has to walk by that time. So, as a neurosurgeon, we would prefer, before the patient goes to 9 year, 10 year, or spurt of growth, when the patient starts deteriorating, we would like to relieve the spasticity by that age. And that is 3 year, 4 year, by that time physiotherapy, if required, non-epileptic procedure for toxin, or if other diffuse spasticity, then we go for baclofen pump. And rhizotomy, if all these have failed, again there are a lot of discussion we'll have tomorrow. If this spasticity is relieved, we feel that one milestone can be gained more than that. At the age of 9 years when we do, the existing motor function can be improved only. Whatever we do, existing motor function, and easy fatigability is also reduced that one, and cosmetic improvement happen. But gaining the milestone, I don't think after that is possible. So some of the growth has occurred by that time. Yes, orthopedician will come picture if the neurosurgical procedure has given limited result, and at the age of 9 years orthopedic procedure. So I would feel before 9 years, if possible, go for neurosurgical procedure, and residual problem, let's take it over by the orthopedician if this spasticity has been totally relieved of. I think that debate may be
To
required.
summarize, yeah. Say if you, as far as Dr. Purohit is concerned, he will say 5 is nice. So before 5 years, you would like to change the spasticity or tone status of the child by doing a neurosurgery procedure. And Dr. Abhay would say that 9 is fine. So if you have to do a orthopedic surgery, you do it around 9 years age plus minus, so that you get maximum benefit because the adaptability of the child will be maximum. But 20 is plenty. In the sense that if the child comes very, very late, you can change the deformity, but the functional gain at that age is going to be very good. So with that age, what is going to be the plan for this child?
This child. Yes.
But he's an adult now, so his desires and needs will need to be addressed, and whatever we decide to do will be with a way of improving his current problem, which is mainly his knee flexion and hip flexion.
What is cause of his pain?
It is an inefficient gait pattern.
So if we improve the gait pattern,
his symptoms will hopefully be relieved, but that will come at the cost of a very long rehabilitation program, because what we would do is in effect make him weaker than he is, and then he will have to build up on that.
So what would be your recipe
For him, he wants to get stable feet to stand on. So with that midfoot break and the equinus, which is mainly gastrocnemius driven, my surgical principle for the feet would be an oscassus lengthening plus very careful gastrocnemius lengthening to just bring the foot into a braceable position, and then orthotics for up to 12 months afterwards, solid to start with, and progress to hinge depending on what his knee was doing. That's at the feet. For the knees, given that he has purely hamstring contracture at this point, the medial hamstring lengthening in the same way, not touching the lateral hamstrings and transferring semitendinosus above the level of the knee. That would be for the knee with just resting the knee in a comfortable position to start with, and going to using Botox in the hamstrings to get some more length, and moving to gradual splinting nighttime as comfortable, avoiding a knee stretch, a nerve stretch, and a psoas lengthening at the...
Would you address the pedal
again, no, because that is an operation where he has no symptoms in his knee at the moment. He's still able to use the quadriceps like you showed. So the gain from doing patellar shortening would be negated by the long period of rehabilitation. Once you mess up the extensor mechanism, you have to wait for it to heal before you can get it back on his feet again. So because it would delay the recovery by 6 weeks, 2 months, I don't think I would use it as a first choice. I would address the other issues first, get him more upright, get him walking on it, and at the end of a year or 2 years, see how he's going. And if then his main problem is still that weak quadriceps, then that could be done in isolation if it fits in with life and career and all the other things.
So this degree of mind patellar can be overcome by quadriceps lengthening?
Yes, we can try, but here the age, because the person is at the moment, he's more than 22 years, so the strength training is also very much difficult. But he has got potentials, and he is a college pass individual. So we can go for maintenance therapy, particularly the strengthening therapy and mobility aids. Because here the role of the therapy is strengthening, and at the same time the role of the mobility aids here. I want to ask actually basically two of you here. What kinds of mobility aids do you prefer at this moment for this person?
I wouldn't prefer. I would give him a list and let him make the choice.
At the moment he's using a walker.
Correct. So,
but walker is to use the walker is not a community walker, because walker is not considered as a community walker aids. So what? And he's going to college.
I would prefer
Yeah.
for him to learn to use forearm crutches
Yes.
or sticks.
That's one of the biggest questions we should consider here. And another very tricky question, that is my particular question, because we will discuss, I hope, in the near future. As he is basically a person with good mental ability, he is doing college, and at the same time, he is now going for some vocational things also. So he has got mobility. At the same time, he is getting problem with the mobility, with the age and non-functional weakness also. So how you feel he will be able to walk? In another words, I want to ask how long he will be able to walk?
So after 10 years or 20 years, what is the...
How long? Yes, because this is one of the